Hello, my name is Stefan Gravenstein, and I'm a professor of geriatrics at the Alpert Medical School at Brown University and the School of Public Health. And I'm also associate director at the Center on Innovation in Long-Term Services and Supports at the Providence Veterans Administration Medical Center in Providence, Rhode Island. I was asked to speak about coronavirus infections and COVID-19 and give it a geriatrics context. So you will hear me do this now. I'm going to share my screen. So you should now see my title slide. Hopefully this is working. And I hope to have a disclosure slide coming. So there is a couple of grants that I have that relate to coronavirus and that are just beginning. I'll be using some terminology. SARS-CoV is the virus. SARS-CoV-2 is the current pandemic virus. CoV stands for coronavirus, and COVID is the disease caused by SARS-CoV-2. We call it COVID-19 because it's this current season, but you can get COVID from other SARS-CoV viruses. I'll also be using terminology that has to do with shedding and transmission. Shedding means when virus can be detected in places. Transmission is when it's actually conferred from one living host to another. So they mean slightly different things. You can shed without transmitting, but you cannot transmit without shedding. All right. So the objectives now are going to do a quick recap of the new SARS-CoV-2 pandemic, do a little bit of epidemiology, and then translating concepts to practice, which includes how we keep the patient safe from us, patient care testing, and strategies specific to concrete settings. I won't be talking about ethics or treatment. You can look those up. I'll have one short word to say about that. So here's some key concepts. This is an RNA virus. There's no machinery for correction of errors and making copies. So that's kind of similar to influenza, which is also an RNA virus. There isn't an exonuclease that can carve out errors in transcription. So the errors that are made in making copies stay with the virus and means some of the viral particles aren't going to be viable, and others that are in a Darwinian way will survive. Unlike influenza, this virus seems to be more stable. And right now in circulation, there are two main strains of SARS-CoV-2. They're called an L and an S strain. They have slightly different pathogenicity. And quarantining probably differentially reduces the spread of the more pathogenic strain, because the less symptomatic you are, the more likely you are to stay in circulation and transmit it to other people. So quarantining will specifically affect those people who are the sickest, who are most likely to follow that rule, allowing the other strain to potentially dominate. The people who wrote the original paper on this suggested that the more pathogenic strain was in the dominant one in circulation. I'm not sure if I'm convinced by those data. There are other coronaviruses out there too. Okay, so that's the first concept. The second one is the virus has a relatively short lifespan on hard surfaces. There's been a few reports on how long that lifespan is. And this depends a little bit on what kind of surface it is. If it's a high polished surface, the ability to collect virus and culture it is longer than, say, if it's on a surface of cotton, where it's quite short, or copper, a little longer on plastics and synthetics. And so you can think about this as how much virus you can find in places depends on where it's dropped. When we think about how it's spread, we think of it more as being spread by large droplets more so than small droplets. It's different from influenza in my mind. The experts might disagree with me a little bit here, that it's not as contagious as influenza. I've heard of multiple reports out there where one person infected with influenza gets on a plane for a transatlantic flight, and many people are infected when they arrive at the other end. So that to me sounds more like a mix of large droplets and small droplets and aerosol. And it might be that influenza actually is a little bit more efficient in spreading. And I think also about how quickly influenza peaks. You know, when it gets into a place, it spreads very rapidly. So we have these peaks typically in January or February, sometimes earlier. And the pace to get to the spike is exponential. And then it rapidly drops away again. So a feature of this kind of spread is that the more it is by large droplets than small droplets, the more it is something that's contained with the radius from the person, because if they breathe or expel it, the large droplets will drop to the ground, and they will do so within a meter or two of where they're expelled, whereas the smaller droplets might go a little further. And if they're very small, less than 10 microns, then they can go much further and stay airborne longer and be inhaled and so forth. So, so this droplet size thing is important. And because with influenza, we sneeze, we get congestion and so forth. The sneezing can produce aerosolization that can make it spread more efficiently. In a similar way, when somebody gets a SARS-CoV-2 infection, if they happen to be co-infected with a virus that makes you sneeze, then you may be able to change the mode of transmission. And I would speculate that the super spreaders might be the people who are co-infected with another viral pathogen, or they have seasonal allergies or some other feature that makes them aerosolize more, so they become more efficient at spreading it. It might also just be that they have higher titers of virus that when they deposit it and somebody else touches the space and makes contact, that there's just a bigger viral load. So I can't speak to which of those things are true, but I believe that sneezing would be a mode that changes transmission and would be a game changer. So, so the reason it's spread more by close contact is if you get on somebody's face, if you're really up close, for example, in doing personal care, like we often do in our nursing homes and senior homes with older patients, then you're in the talking, spreading, direct contact, and touching, where you don't know that you're touching your face, place of transmission, and the likelihood of getting infected is much greater the longer you are in that range of close contact. So the face-to-face time is really an important thing. It gets into the air, but it probably doesn't transmit efficiently through the air if you do social distancing. So here is a short video that I think first aired in Australia with a commercial. And this is a description of what people have when they have allergies and influenza and rhinovirus infections and para-influenza infections and RSV infections, but not so much coronavirus. And what I want you to see in this video is that not only do beautiful people sneeze, but when they sneeze, just like the rest of us, they produce a variety of sizes of particles that they expel. And so now as we go to that part of the video, you're going to see the entire range of particulate matter that comes out as they sneeze. And as you look at this, you will also see in the frames that there are these very small particles that project more directly out, and they can go a long distance. And the smallest ones can be expelled 5 meters or more out. So if you think of this in a slightly different way, you can see this high-speed frame to look at how these particles are propelled. And so when you think about this, the large particles that come out, if it's just from exhalation, they will drop to the ground within 1.5 meters. If you're coughing, they could go up to 2 meters. If you do sneezing, they could go up to even more than 6 meters. When you put masks on, the surgical mask will get particles that are greater than 10 micrometers. And this is an effective way to block the splatter. And that is, in fact, how much of coronavirus is produced. It's in a splatter format. So in general, in the public space, when we're wearing a mask, it protects the people who aren't wearing it from the people who have the disease that are wearing it, because the mask traps what they're breathing and so forth pretty effectively. A regular surgical mask will not very well protect you from that large particular matter, because if it's in the aerosol, it'll get around the mask because not everything will go through. Also, the filter isn't as efficient. Now, if you want to be able to get smaller particles filtered, an N95 mask would be the right mask for that. So this will get particles that are bigger than 3 micrometers, and it's about 95% efficient for that size particle and 100% efficient for bacteria. Now, you could also get N99 masks, which are 99% efficient for the same thing. But remember, if you're getting an aerosol that you need an N95 mask for, if those viruses are suspended in air, the hang time, if this is not just seconds, but minutes or hours, then these aerosols can also get into your eyes. So an N95 mask would be necessary, but not sufficient to protect your eyes. You need eyewear ideally too. A face shield would be a good start, covering the front of the face and going down. But goggles or something else would be even more effective. And you can see on the right, there's all sorts of strategies we use in the US to help protect ourselves from others. So, except in the setting of aerosol production, the function of mask is to emit fewer infectious particles in most settings. That means since you can be asymptomatic with coronavirus infections, when you're wearing a mask, you're acknowledging that you don't know whether you have infection, even if you've been safe and inside. You don't know if you've been self-inoculated by some other accident. And the wearing of the mask is protecting others from you until you get into an N95 mask. Then it's actually working in both directions. So a second part here is what happens as the particles get into the room. So when you cough and sneeze, it gets deposited in the workplace, on tables, on beds, on the bed rails, on the iPads, on the phones, on the doorknobs, on the windowsill, on the floor. There was a study that was done that started looking at where these things were deposited. And essentially, there was a lot of depositing, even on the floor. 80% of the samples were able to be deposited on the floor or on the windowsill. You could test it. Interestingly, when they did air sampling, both personal sampling and the volume of air, the samples close up and even 2 meters away were still positive, but they were not able to grow any virus from that. That study was done at the University of Nevada and is presently in preprint. A second interesting article is that the louder you talk, the more particles you can emit. So there was an example of a choir where they did social distancing within the choir. They came in. There's actually some things where they touched similar things like the fruit and the furniture, but they thought that they did good social distancing, yet many in the choir became sick from one of the contacts that was there. And the thing is that if you are singing very loudly, which choirs do, their efficiency of transmission will actually be better, and they can produce aerosols that can stay suspended longer. And in this case, there's an example of transmission. There was another example of transmission where the only known contact was an infected person who passed a salt shaker that became infected to another individual. So now I've told you that it's genetically stable. It has a relatively short lifespan on surfaces, and that translates into if you're wearing a mask and you want to use it, if you put the mask in a paper bag, something that's porous, within 3 days, the virus will no longer be viable and cannot be transmitted. So if you don't have a way to clean it, if it's not visibly soiled, you could, in theory, reuse it. Even a few hours like that will result in very little of the virus left to be spread. The next concept was that this is mostly spread hand to face, things that you touch, and direct splatter where it's been deposited. And that splatter, you touch somehow, not knowing that you touched it, and then you touch your face, your mouth, your eyes, your nose, and then you self-inoculate. All right, so when this inoculation happens, if you breathe it in, it can get directly into your lungs. But if you put it on a mucosal membrane, there aren't really any readily available receptors for the virus. The virus binds to an ACE2 receptor. This ACE2 receptor is how it attaches to tissues to allow itself to get in. In the nose and in the nasopharynx, there are no ACE2 receptors that are available. The ACE2 receptors are in the basal layer of the non-keratizing epithelium in the oropharynx. So that is underneath other stuff. So just having it in your mouth doesn't actually infect your mouth or your throat. What this means is it has to get to where there's an ACE2 receptor. And there are two locations it can get to. One is in the lungs, which has them in the alveolar cells. And the second one is in the small intestines from the end of the stomach, the beginning of the duodenum, all the way to the ileum. That, when it infects that, it gives diarrhea. And an older person might, in fact, have diarrhea as their presenting symptom, not a sore throat or anything else. And the diarrhea may actually get better before they have the first symptoms. So what I believe happens is the lung or the intestinal tract are seeded, and then you get a viremia, which is very common with SARS-CoV-2. I believe it's relatively uncommon with influenza, and that viremia now can attach to many other tissues that have ACE2 receptors, including through the viremia in the back of the throat, the pharynx, where now it can attach to those, to the basal layer and cause the pharyngitis. So the pharyngitis is actually a sign that they've already been infected for a few days, on average 5 days, and maybe as many as 2 weeks. And that there's some other area that's already infected too, either intestines or lungs, that were the prerequisite for it to get in. Now it binds to the kidneys, and it binds to the endothelial cells and arterial walls, including the heart and the brain and so forth. And that can cause a vasculitis and even encephalitis. For the kidneys, it binds to the brush borders of the proximal tubules. And so there's been some concern about whether you need to change therapy if you're using an ACE inhibitor or angiotensin receptor blocker. And that is that protective effect of the ACE2, which is eliminated when the SARS binds to it, may in fact be part of the pathogenesis. And you don't have already as much of the ACE2 available in diabetics. So the concept here is it readily seeds the lower respiratory tract and the intestines, not so much the oropharynx. That is a secondary problem. So it's stable. It has a relatively short lifespan on surfaces, especially cotton and copper. And it's spread from hand to face, direct splatter. That's probably, in my mind, the major mode of spread. It readily seeds the lungs, not so much the back of the throat. And we are the vector, we people in general, because if you don't know that you have it and you can still walk around, you can be readily transmitting shedding virus, which could be transmissible to others. In fact, there's now evidence, several cases where they've had people who have been asymptomatic and were the vectors to multiple other people. So SARS-CoV-2 is now in community circulation throughout the US, Europe, and elsewhere in the world. In 2003, SARS had a community spread, and the second wave was entirely nosocomial, which means it was given to healthcare professionals who then got sick, and because they were taking care of them, would then go out and retransmit it. So we are the healthcare workers, and so we should all behave as though we are the vector if we go out and about. If we're just in our own room and we aren't out, and we have been out for a couple of weeks, then we won't be vectors at that point. But when you go in the community, if you're not wearing a mask, you're not reinforcing to others that they also should be wearing masks, which actually would keep you safe. So this is a public messaging. So we should consider everyone we see on the street or in practice as potential vectors until the SARS-CoV-2 activity starts dying down. So the next key concept is asymptomatic and symptomatic spread occur readily. And the longer they have symptoms, the longer they have shedding. So early on, in the first 5 days or so, shedding is roughly the same in volume of virus, both in those that go on to have disease as those who recover. But the ones that recover stop shedding, and the other ones shed longer. The second thing is, the longer you have symptoms, the later you develop immunity. So if you're still having symptoms for 2 weeks, there's a chance you don't have immunity yet, and you may never get immunity. So this is a slide that says some of this. If you have, there's a quarter to half of them who will never get symptoms and still can transmit. And then in the early phase of infection, you can have some mild constitutional symptoms. Diarrhea or dry cough are usually one of the first two. By the time you have headache, there's probably already a little bit of a viremia. And in this early phase, you might see some lymphopenia, an increased prothrombin time, D-dimer, mild increase in the LDH. And then there's a response that begins. And in this early phase, in the viral response phase, the ones that become sick are called pre-symptomatic. And then there's this group that's asymptomatic that never gets sick. So as soon as they come out of this pre-symptomatic period, they usually go through this step, but they don't have to. They can jump directly to shortness of breath and abnormal chest imaging, because after all, if their lung got infected first, their initial symptom may be a chest symptom and a low O2 saturation or something like that. So we have seen in our nursing homes now 2 types of presentation where they didn't have any of the prodromes. One type where they had tachypnea and they were in respiratory distress and we could rush them off. And the other type where we were measuring a pulse ox and they were suddenly hypoxic, and typically they would die without any additional symptoms, usually pretty quickly. So a different, very different kind of presentation in these old nursing home residents. So this period here is the pulmonary phase. And then somewhere around day 5 to day 7 of illness, when the innate immunity is supposed to be building up, it's supposed to now flip into an adaptive immunity. In some people, it doesn't, and that is more likely to occur in older people. Immune senescence impairs the flipping of that switch. And if you could down-modulate the immune response and get an adaptive response, more like a healthy younger one, you should go on to recovery. But if you don't, it becomes hyper-inflammatory, and you will get a cytokine storm that may persist and lead to respiratory distress, shock, and cardiac failure. And also you'll see this progressive increase in inflammatory markers like C-reactive protein, interleukin-6, troponins, B-type natriuretic peptide, and so forth. So this is an example from James Cameron, work that they've done on the original SARS virus. And it shows this switch here that happens between day 5 and 8, and the changes in cytokines and what happens with immune dysregulation of aging with viral dissemination. Here with viral clearance at the top. So we are the vector, and we can spread it asymptomatically, as can others, but more symptoms mean longer shedding, later development of immunity, and there's common symptoms in adults, with the common symptoms of dry cough, fever, and fatigue coming already after many days of asymptomatic shedding. In nursing home elderly, they may skip the fever altogether and go right to tachypnea, and they might even skip the cough. They might present with a dropping pulse ox and may not complain of anosmia. So if they present with cyanosis, delirium, hemoptysis, those are a little bit more ominous. Leukopenia, maybe or maybe not. but AKI is also, acute kidney injury is also potentially particularly ominous sign. So in this slide, I would take issue with this nasal congestion. I do not believe that that's actually caused by their COVID. Instead, I think that's allergies or secondary infection with another one. It is an infrequent sign, and I have not yet seen it in any older COVID patient. So I think it's from concurrent infection, and other experts will probably disagree with me on that. Whereas sore throat, pharyngitis, headache, and these others are exactly as reported here. And I think diarrhea and sore throat are particularly common in older adults, as are chills with or without fever. In severe disease, you'll see also typically geriatric symptoms that include potentially difficulty walking, delirium, cyanosis, and persistent chest pain, often substernal chest pain. 80% of cases or more are mild, 15% are severe, and 5% become critical. And this ratio is calculated in the context of limited testing. So as we discover more and more people are asymptomatic, these numbers, these percentages will probably drop down. But this is with people presenting with meaningful clinical disease, the kind in an era of insufficient testing probably represents about what you'll see of the people who get tested. My guess is that the actual background critical cases is going to be just a couple of percent once we have the denominator actually figured out, all the people who aren't tested that actually belong into that mild or very mild scenario. All right, so common symptoms in adults is dry cough, fever, and fatigue, hypoxia, and old. So now let's shift a little bit more to geriatrics specifically. Kids can get congested, adults don't. It's hard to stay home, and there are limitations from lifelong habits to degree of fastidiousness. So getting older folks to actually stay at home, at least in the US, has not been that easy. They'll do it for a few days, but pretty soon they wish to get out. And it has been striking to me that when I'm out and doing my shopping, when I see folks that go out and they think they're doing social distancing and not touching things, when often they don't do either of these well, especially if they're shopping. They're trying, but they don't recognize that all the things around them where viruses shed onto surfaces are potentially places where they could be picking up things, and then people touch their face 90 times a day without knowing it. There's this risk that they can self-inoculate. And so I think that's harder. And if they have lesser education, or if they're in very close housing, like in America, our minority populations often live closer together in closer quarters. And they also become the service population that are out, not able to shelter in place because they are doing the food deliveries. And they are doing other work because they are needed for those services. They're actually getting exposed, whether they like it or not, and they are at risk then for having outcomes. So living in congregate housing amplifies that risk, and we are the vectors. So there's one specific nursing home, the first one that cropped up in the US. It was called Kirkland, and this is in Seattle, Washington. And there's a nice paper that describes this. I'm just going to do a couple of slides from that paper. And what you should see here is on February 19th, the index case had its first symptoms. It had shortness of breath and got some supplemental oxygen. 5 days later, on February 24th, they were hospitalized on oxygen, and the oxygen saturation was 83%, so quite low on room air. And even though they were elderly, they still were able to mount a temperature of 39.6. The next day, they started having respiratory failure, and they did a rapid panel for a panel of respiratory pathogens, and it was completely negative. So this is a person with diabetes, heart failure, hypertension, kidney disease, obesity, and on chest x-ray, they saw a diffuse pulmonary infiltrate, and a smart physician said, well, we should probably get a COVID test. And this was at a time when they were almost unavailable in the US. They ordered it. The public health was notified on that same day of the 27th. that there was a 73-year-old in the facility also with fever, and there were several other people who were short of breath in a cluster of respiratory illnesses. The next day, the test from that first patient came back positive, and in a healthcare person test. And on the next day, on the 29th, that first index case died. Ultimately, as this unfolded, and that's what you see on the slide here, this graph of people becoming sick, many people got sick. Residents, healthcare personnel, visitors. 167 confirmed cases in 101 residents in a facility with 120 beds. 50 healthcare personnel, and 57%, almost 2/3, went from a pre-symptomatic to a symptomatic period in a space of 10 days. Personnel and 16 visitors had this evolution. 7 people were completely without symptoms the entire time. Hospitalization occurred in half of the residents, half of the visitors, only 6% of the staff, they were much younger, and 1/3 of the residents who were infected ultimately died. The second part of this is you saw wildfire spread through the facility, explosive spread. There's other words you could use for this, but very rapid spread. There were healthcare workers in this facility that also worked in other facilities. So we call these contract staff or per diem staff. And so in facility A, this is now the Kirkland facility, worked also in facility B, and transferred patients to facility C and D, and shared another healthcare worker with facility E. And those facilities also had healthcare workers that were shared with other facilities. So you could actually look at this and see how it's getting transmitted between facilities. By March 18th, so just a couple of weeks later, 30 long-term care facilities had at least one confirmed COVID-19 case in King County. So this is the sum of the parts and reasons of this outbreak are the staff worked while they were symptomatic. In the US, many long-term care settings are short-staffed. If somebody calls out sick, it's hard for them to have other people coming in. The staff worked at multiple facilities, so they became vectors of the disease. They didn't have familiarity and were not adhering to the standard droplet contact and eye protection precautions that now have been hammered into these providers. So that lack of familiarity is, I think, also getting a little caught off guard. In the US, we have a requirement now that there's an infection preventionist, typically a nurse, whose job it is to make sure that everybody stays up to date on infection control. But having them do this and teaching it, as you know, doesn't always mean that it translates into action, what people actually do. And nor if you teach it, even if they can say it back to you, doesn't mean that they actually understand what they're supposed to do. And so this is, again, one of the challenges we have. The facility had inadequate supplies of personal protective equipment. Not so hard when you have 1 or 2, because facilities usually prep for that kind of level of stored up equipment. But as the entire facility was blossoming with all these infections, they just used up far more than they could have ever imagined, and hand sanitizers. And that made it really hard to implement effective protection control practices. In February, in the US, we were saying there just isn't much coronavirus in the country anywhere. So why would we worry? We had one person from China who was infected and had made it to Seattle, but there wasn't any reason to think that it would suddenly show up in the nursing home. And so not being suspicious of it also made it hard to say, when you had a couple of people who were coughing in your facility, to think, oh, it's coronavirus, because at that point they hadn't even figured out what the presenting symptoms were. And the people working in nursing homes aren't usually the first ones to learn how to diagnose these new incoming infections. It takes a little while for that knowledge to get transferred. And then they had limited testing availability. We were still in our country trying to figure out who to test. With very few tests, then you test the sickest people and you tell the other people to stay safe, but we weren't exactly sure what staying safe meant yet at the end of February. we didn't learn from what was happening in other countries as to how extremely careful we should have been. So it was a difficult diagnosis also in old people based on signs and symptoms alone. If you're expecting a cough with a fever and the person doesn't have a fever and they're not coughing, but they're still getting respiratory distress, again, they'd have a reason not to necessarily detect it. So what you have to do is you have to start off by thinking about how do you do the staff training on using personal protective equipment. That includes how do you take the mask off and on, donning and doffing, we call that, as well as gowns and so forth, gloves, how you worry about contact transmission in common areas. So when somebody touches something, recognizing that if they haven't been masked and they're asymptomatic, that they're actually depositing virus in the process or just by breathing. And how to think about inventory and plan for shortages and alternatives. 75% of long-term care facilities in the US are short on personal protective equipment. Even as rapidly this virus is spreading from one long-term care facility to another. A week ago, we had gone from 150 facilities in the country 2 weeks ago to 400 last week. And again, it's gone up dramatically in the week since then. Stopping non-essential visitors, screening those that enter the building and screening staff. That includes not just the nurses who have direct contact, but all the people who can give it to the nurses or that mingle, that includes housekeeping and working in the kitchen and so forth. 57% of the asymptomatic became symptomatic in 10 days. So there was a 10-day window, where people were shedding virus. And if you're not screening all of the people who come in, then you're missing a chance to stop the spread. If they are symptomatic, they've already been shedding, so you worry about who else they gave it to. And if they have an elevated temperature, they've already been shedding for many days before that. So if they've been working, you have to worry about who they gave it to. And that means that very aggressively, you need to think about whether you need to test other people in the facility. We don't do handshakes anymore. You don't do touching or hugs. We try to do this all at a distance. The facilities now, we are recommending that they know who their contract or per diem staff are, the ones that work in other facilities and where else they work. So if you hear that there's an outbreak in another facility and you have somebody working from there, you say, well, you can't come, you now have to be out for 14 days. And I suspect, we do not know yet, that the outbreaks that are in the facilities that have most of them so far use, I'm guessing, more contract staff than others. We still have to prove whether that's true, but I suspect that is the case. You'll see at the bottom of the slide here a place where you can get a nice list of things for disaster planning specifically like this. So you want to minimize contacts and contact time. So when somebody is doing personal care, how much time they spend with them. And there's a variety of things we can do at the facility level that can help with this. For example, reducing the number of medication passes. So if they are getting a medication prescribed 3 times a day, can you make it twice a day or once a day? So you don't have to go in any resident's room at all, as often. So we've done this with all of our residents. If you can do the visits as a healthcare practitioner via telemedicine, so if they have a phone by the bedside, you can call them up even if you're standing in the doorway, so you're good 6 feet or 2 meters away. If you can do contactless vital signs. So contactless vital signs, for example, using something for temperature that doesn't have to touch the resident, but does it from a distance. If you do respiratory rate, maybe skip some blood pressure measurements if you don't need to do them. Consistent assignment is when we have the same worker with the same resident for every time they are in the room. So the more you can schedule the same workers with the same residents, the less they are with other residents. So if this resident gets it, it limits their contact potentially with others. If you lengthen the shifts, so they're 12-hour shifts instead of shorter shifts, 8 hours, maybe they don't work as many days, but that lengthening of the shift, again, reduces the number of people who come in the room. If a person has to go in the room to do a med pass, if you can make them more, we call it a shabazz, a worker who can do many different things instead of just that one duty, you get them to do not just the med pass, but you also help them, make them do the personal care and the transferring and other kinds of things. So it's only one person who's getting in close contact instead of 3 or 4 staff at once. And they do all these activities at once. So one entry in the room, one set of personal protective equipment that you have to shed when you get out. And they do all these activities in a clustered way all together at the same time. And of course, stopping the outings so that you're not taking everybody on bus rides or eating in the dining room together. You keep them in the room as much as you can and as is feasible. You want to adjust the practices, and this is one of the ways to do it, so you can help preserve your personal protective equipment. And that also means reusing masks. So if everybody is issued, for example, 3 masks, they'll have 3 bags, paper bags. And when they finish a mask, they put it in a paper bag. And the next day they take it out of the next paper bag, so that you have this rotation where you could reuse the masks if you have 3 that can then be used over a period of many uses instead of just a few. You don't want to generate aerosols with the virus. So nebulizer treatments in the hospitals, we also try to avoid BiPAP. And if we don't have to mechanically ventilate them, we try to avoid that. Intubation produces aerosols. But the nebulized treatments is something we are accustomed to using a lot in the US. And so figuring out how to change them to oral treatments from these nebulized treatments. There may be also some things where they can, dry powder inhalers and other things where they don't produce an aerosol. That might be an alternative. Suctioning is also a problem. So instead you would turn them instead of suctioning. Platooning the care and cohorting the residents. So what this means is the staff that are working on a specific ward, you don't have them work on another ward. You try to keep them all on that ward. And the same with the healthcare professionals. So in our practice, we have one physician now that's assigned to a specific nursing home. They can cover over the phone for other ones, but there's only one place they go in. And they don't also, we normally also go in the hospital and other places, but now we have stopped doing that because we're worried that when they're in the hospital, they could get infected and then bring it to the nursing home. So we're keeping them just for that individual nursing home. And the same with our nurse practitioners and physician's assistants. So platooning our care to a building for our doctors and nurse practitioners. And within the building, the healthcare professionals that are in the nurses and CNAs and so forth, that they are platooned within a specific ward so that they're not going between floors. Considering a daily or a shift resident as contactless, vital signs, so that when you're doing vital signs, which you might actually want to do more often now, but specific, if you're going to do more often, consider the contactless approach so that you don't have to worry about contaminating your instruments and other kinds of things as you go in and do it. And then every time you do this, even if you're close with a thermometer that is not touching, that you still wipe it between uses, so when you set it down, it's actually clean. It says, here it says, worry about a temperature of 99, that's 37.2 Celsius. If you have 2 measurements of 37.2, I'd consider that a fever in an old person, or more than a 2-degree difference from whatever their normal range is, Fahrenheit, or 1 degree difference, Celsius. So if they have a temperature of 38, that to me is clearly a fever. 2 temperatures of 37.2 is also a fever in an older person, or a change up or down of degrees centigrade. If they are using an electronic healthcare record, you can develop a user-defined assessment that'll improve consistent reporting on items of interest. So the COVID symptoms and signs would be an example of a list of things that they could have in a user-defined assessment in an electronic record. So that would include things like cough and sore throat and pulse ox or hypoxia or cyanosis and anosmia, loss of smell, which can occur in up to half, tachypnea, headaches, myalgias, diarrhea would be sort of high list on my symptoms, cyanosis. So this was a map of the US accessed 4 days ago. And what you should see here is that there's a lot of activity down here in Florida. And this is a map of the change in temperature. So where it's red, the temperatures are rising. And where it's less red, the temperatures are actually starting to come down in some places. So New Orleans area where they had the Mardi Gras on March 15th, it looks like it's cooling off a bit. Miami still had the beaches open until just 10 days ago from now. And you can see this is still heating up. So Florida will be a new hotspot. And then here you can see still King County, this festering activity that hasn't quite cooled down, and Denver, Colorado. I live here in Rhode Island, and you can see in Providence, which is where our Brown University is, we actually have a bit of activity here. And part of this is we are called a bedroom community for places like Boston and other places where there's still a lot of activity. And even people from New York City come to our area specifically with holiday homes and places to escape when they don't want to be in New York. With that temperature map, this national temperature map, which gets over 1 million readings a day, you can see that nationally our temperatures were declining at the end of influenza season. And then at the end of February, we started getting this bump up. So even before we were aware that we had coronavirus cases, there was this now brewing activity. And we had, by the beginning of March, we already had some cases where there was no contact tracing available to say where they'd gotten from. And you can see here, there's where the red dots are, there's dramatic regional rises for the country as a whole. So when you can start seeing these things going down, that's when we start doing messaging about you really should stay home. And here's where we started saying individual states were putting in orders in place. You must stay home. Only essential businesses stay open. And so you can see how this dramatically affected the relative rise across the country. Now, this is even with the Miami area in Florida still on the rise. We're getting this downward trend. So it's an average for the entire country. Also one more thing here is that, so this turns out to be highly correlated to flu activity. And at the back end on the left side here, and now it looks like it's pretty correlated to what's happening with coronavirus. And it gives you an idea of what's going to happen clinically as they present a week or 2 weeks later. Okay, so one of the jokes we have here is, especially with my life, it's completely changed since coronavirus came around because I spend hours every day talking about this. So we have these interminable meetings. These are meetings that never end. And this is a humorous paper on that they don't actually help in the treatment of COVID-19. So I thought you'd enjoy that. Something else that you can get is you can get an infection log that is built in a spreadsheet format. We have posted this log as a template on the website at Brown in the Q&I Center. And this log allows you to build so this is a line listing of each person who gets infected with something like a fever. And in this case, they have a respiratory infection or a multiple treatment for the same thing or a UTI. And so you get a room number and resident number and you do this line listing. That's what every nursing home does. This log comes with an area underneath on the same spreadsheet that has a space for a floor plan. And if you take this log and you log in, you can put the floor plan of your own facility in there. It's a design so you can move these rooms in sections and draw them out. And the formulas, if you're dragging them in blocks of rooms, follow it so that as you populate the floor plan, it will know that if you put somebody in room 4 who has a respiratory infection, it will then in the floor plan light up room 4 and in this key with respiratory infection and that symbol. So if you don't have color, you still see the symbol. So here you can see that there's a cluster of things that are happening close to each other. GI, which could be diarrhea, and 2 respiratory infections. And that might tell you that this is actually a COVID cluster because those are all symptoms you think of with coronavirus. So a case. This is now taken from the reference at the bottom. You have an 82-year-old woman and she has diabetes. And we're saying it's April of 2020. She has multiple morbidities and has had a cough for a week, not feverish, no temperature available. She hasn't been traveling. 3 weeks ago, she was returning from Europe, which was probably one of the early places we seeded in the US. And she had a finger stick glucose that was running a little higher than usual in the 180s, according to her daughter. And her daughter thought maybe she'll go worse than her baseline. And the question is, should she go to the emergency room? Should she go elsewhere? Should she be tested? Would this be more likely to be COVID if she were a he? In other words, if this was a man presenting instead of a woman. So we'll answer those in a moment. So Just by being old, of course, we have a greater susceptibility to be infected, and clearance of virus is less. The mucociliary escalator doesn't work as well. Immune senescence, the ability to fight the virus with immunity, is a little less. And there might be underlying issues with nutrition that can also make you more susceptible and harder to recover. And there's a diagnostic challenge because fewer than half will ever mount a temperature in this range of over 99 or 37.2 Celsius. They may or not feel short of breath. So pulse ox or pulmonary exam may be the first clue that something's going on. They might not produce as much sputum, and it might be because of medications they're on, or just they don't produce as much, or they're not hydrated. Their first symptom might be some confusion, and if they're already a little confused to begin with, it may be hard to say if this is just a little variation of the baseline or if this is something new. But they might have a chronic cough or heart failure or asthma, other things that might make it hard to know if this is a new thing or just an existing thing that's acting up. And many of our older patients don't complain. They say they're fine. And even as they have tissues, stuffed in their sleeve or in their bra, they may not complain of anything. The case fatality rate in old people is high. They have reported that 89% of the COVID-19 deaths are in people over the age of 70. And this breaks out to 58% of those are in the over 80 group and 31% in the 70-79 group. So age is really an important risk factor for dying from this disease. So what is a fever? In China, 83% of 99 patients had fevers of greater than 37.8, but their average age was 55. So they're not talking about old people. And they had criterion to screen for fever in the first place. So they were only letting people in with fevers. They weren't testing everybody. And that, of course, has changed as testing has become available. So this is not a good representation of what happens with your patients and my patients that are elderly, because fewer than half will actually have a temperature than this high. Not even a third will have that temperature. So with flu, only about a third of adults have temperatures that of people over the age of 60 have a temperature of 100, and coronavirus is no difference. In a nursing home, fewer than half of those age 85 have a temperature that is over 37.2 at any point in their illness. So a fever could be 37.8 or 37.2 if you measure it twice, or an increase or decrease of at least 2 degrees. So this is the he-she question. And what you should see here is that men are much more likely to have critical illness with coronavirus infection than women. And this is across all age groups, but the difference gets bigger as they get older. So this is a second one. Now, this is a person that is in a nursing facility, a skilled nursing facility. We're saying this is March, and it's a man. He's 86. He has a 2-day history of cough. He's short of breath. He has chronic lung disease, atrial fibrillation, dementia, and he knows where he is and who he is, but he doesn't know much more. He's not able to walk. He has 2 people to help him with transfers. He is sent to the emergency room, and on the way to the emergency room person lets the facility know that there's dozens of people with upper respiratory tract infections in the emergency room, and the emergency room is holding ICU patients for an average of 20 hours. And at this moment, let's say in your place or in Rhode Island, which is how I constructed here, there's only a single case of coronavirus infection, COVID disease. The patient is awake and alert with a temperature of 38. His oxygen sats are 87%. His heart rate is 108 irregular. Respiratory is 27, 102, and 62. And he has a wheeze. So the question is, what do you do? So you're going to do the standard COPD intervention, or are you going to change this a little bit? Should he be intubated? Should dozens of other patients from the same nursing home come to the same emergency room? Can the facility, if he is sent back to the SNF, will they accept him if he doesn't get a test? So what do you do? So the general setup that you should have done that would ideally have been done beforehand would be that you do what we call forward triage from the senior living environment and homebound. So you call ahead and say, do you want to send them? Because maybe you'll send them to a different emergency center than this one if it's really packed. And maybe they'll have a different way to bring him in, because if this person actually has coronavirus infection and he's mixed with other people who might not, It can create an issue because they'll be shedding it and they might want to put a mask on him so that they do other things in just the way they bring him or where they take him. You want to put protocols in place for the facility ahead of time to anticipate that kind of a triage. And that has to be done in collaboration with the hospital and, in our case, also the Department of Health. If the facility had been closed to admissions and some rooms would have been emptied up, and that would have provided some potential rooms for isolation, and that would have been a good spot for the first few to get symptoms if they couldn't send them or if they had to wait to maybe mitigate transmission within the facility. Having said that, since people can transmit asymptomatically when the first resident becomes sick, you have to be suspicious about everybody else being sick, especially if they're in the same space, perhaps less if you've already done the cohorting and platooning that we talked about. So there might be a chance to do testing triage. So you say, well, I'm going to test these people because they're the sickest if you don't have anybody else in your facility that's sick, since there's only one in the state, say. So you might take the sickest and test them and say, do we have it in the facility? I just need to know that. And you have the doctor or whoever it is on the other side do a telehealth evaluation. So there's a video screen where they can see the patient and talk to the nurse and get the nurse to listen to the lungs without having that healthcare professional necessarily come in and decide whether they need to come there. Advanced directives might need to be updated. So in our facilities, we've been actively going in saying, we have this virus coming through. You need to think one more time. Do you want to be taken to the hospital if you get sick enough that you need that? Or do you want to just have us keep you comfortable here? What is your plan? And so forth. So those conversations have been reinitiated. Also, you want to think about how you're going to do your priority testing for the highest risk. So when tests are in short supply or when they affect treatment decisions, those are clearly when you do highest risk. If you have plenty of tests around, then I think, especially in closed settings like nursing homes, you want to be testing more broadly. The COVID risk for getting it in the emergency room is particularly high, so redirecting well patients elsewhere. And we do that outside the emergency room now, where we take people who are there because of symptoms or because of contact and worry. They go to one place and the other people get triaged to another place. Still, we treat them all as if they're potentially infected, but we do that extra step. We put protocols in place for the paramedics, so they also send them to the right location. So the atypical symptoms, fever, cough, and dyspnea may be absent. They might actually be hypoxic, but not short of breath. When you see new delirium, falls, weakness, malaise, conjunctivitis, hemoptysis, anorexia, these are atypical symptoms for COVID in older adults. So when you see these, you should be worried. The typical symptoms for COVID are cough and diarrhea, anosmia, feverishness, and increased sputum. And these other things can occur too, but they typically occur a little later in the course of the illness. You'll probably already have diagnosed them by that time. The presenting symptom may be delirium, tachypnea, hypoxia, and hypertension. Older adults may present with mild symptoms, and they may not look nearly as sick as they actually are. So know that older adults presenting with atypical symptoms have more adverse outcomes than those with typical ones, and consider whether they might have co-infections. And now that the allergy season is coming, worry about whether they might be more efficiently spreading if they happen to have allergies. So if they're presenting with delirium, is it COVID? Well, if it's in your differential diagnosis, then you need to swab them for it and put them in isolation precautions. And you want to add it to your differential diagnosis if it's in circulation in the community. In that second case, not so much yet. If there's COVID exposure, so known contact, if there's hypoxia absent, or hypoxia without other symptoms, so they O2 sats are under 90. If you see them with rapid clinical deterioration, you don't have an etiology for the delirium. If there's a chest X-ray with pneumonia, whether it's uni or bilateral. So does that elderly woman need to be seen? Should she have a COVID test? Should she have an influenza test? Where should she be seen, or do you just wait and follow? And so in our context, we didn't have a lot of tests available. And so we would manage her at home and follow up with her with telephone calls to see how she's doing. And if we could get a test, probably we would, at that point, we would do a flu test because there wasn't much happening in the community, and flu was actually a little bit more likely. How about the elderly gentleman? Does he need to be seen? And he's on a nebulizer. and you might want to give them BiPAP. That's air sterilizing procedure. So we probably don't want to do those things. We do want to have a power of attorney discussion on goals of care, ideally before intubation. Power of attorney is because he's demented. You want his legally authorized representative to have a conversation about how aggressive he should be treated. Should the other dozens of residents from the nursing home come? We actually had a nursing home do that, where they had a person positive, and then they were worried that they were short-staffed because they couldn't take care of all these people who were presenting at about the same time. And they started sending them out to the emergency rooms, and we needed to help them figure out how to manage it, so the Department of Health again stepped in and assisted. If his status improves, can he go back to that facility without a negative test? So we've had a discussion about this, and the recommendations have been evolving. Now, anybody who comes from the hospital to the nursing home must have a negative test before they are sent. Now, it doesn't actually change what we do, because if they have a negative test, because the tests aren't always true negatives, there's some false negatives, we will still, when we accept them back in the nursing home, we'll put them in isolation for 14 days. We'll quarantine them. We don't have many negative pressure rooms. If facilities have one, it usually is only one, but there may be zero, and ideally that's where they go. If they came from that and were COVID positive when they left, there's probably other people already, so there's an issue also what you do. And if you have somebody who's COVID positive and you want to send out, ideally, if you have a COVID positive test, you would send them to a COVID positive facility. So for the outpatient office practice, televisits, almost all of our visits are now virtual visits with telephone or FaceTime or something like this. And we do that as much as possible. We have some older patients where that doesn't work well, but the telephone can work. And it's actually been pretty widely accepted. Many of our older patients have systematically been canceling their visits. We've been rescheduling to do them via televisits. The second thing is we want to make sure that part of that visit is to remind them about how important hand washing is and how they use personal protective equipment, and whether they can improvise and make their own, and what that looks like. Educating them on the threats of any family member visiting, so that they're a little reluctant to have their kids and grandkids come in while this quarantining is happening. Being extra careful and giving them confidence that they can manage this. That caregivers who are helping them with other things can also be infected, and that they need to be concerned about whether they let them in or can manage on their own for a while, because when they come in, they touch things, and then they have to go around and clean and so forth. And then we have to educate them on how to clean and what to use. Now, there's plenty of resources available in every country now online, and also in the US. And we recommend that they go to the CDC site so that they can see what's there and how to make their own cleaning solutions if they wish to make them. And the advantage of that is if there's a change in the recommendations, and they have been changing, that they can find a place that's going to remain current when they go back and look. And so we tell them to look what they say, and in a week or two, look again to see if anything's changed in case they need to do something different. So figuring out how to make these resources available, also make them available to partner facilities where you provide care for staff and so forth. So in my case, I've actually gone out and purchased face shields because they were hard to find and the facilities were running out and couldn't afford them. And we were running out of gowns, and so we were buying raincoats with elastic cuffs that could be used and disposed of for less than a euro. You can buy these if you buy them with enough of them at the same time. And now there's places that have been popping up to try to give free masks to healthcare professionals and shields and so forth. So all of those things are things that may be available in your communities too. For management of symptoms in the home, I don't need to go over this slide. You can have these slides made available to you. So have a protocol, worry about dyspnea and when to use narcotics, and avoid aerosolizing the virus. Think about paracetamol, acetaminophen as your first line. Narcotic and NSAID maybe not so much unless they are dying. Manage the constipation, the anxiety, the restlessness, nausea and vomiting, and the excess secretions. And I gave you some links for the palliative care associations that have specific recommendations at the end of life. These are free resources. So the key concepts were, it's genetically pretty stable, but there's actually a couple of strains out there. It doesn't live on surfaces very long, so if you know how to manage it and clean them, or you can just set them aside. So when we bring groceries into my apartment. The dry goods actually get set aside and they just stay there for a few days. And the cold stuff we will spray down with a bleach, hypochlorite, a Chlorix solution, about 5 milliliters. So you can again look up in your country what the recommendations are. They'll have something for you there. But there's also other common household cleaners that you can use to wipe things down before you put them in the fridge. Putting them in the refrigerator or freezer doesn't kill the virus. So if you think that somebody who's handled the products could have contaminated them, then having a cleaning step is a reasonable thing if you haven't yet had the disease in yourself or your family. We said we are the vector. It seeds the lungs and intestines, not so much the throat. So by the time you get the sore throat, you've been infected for a while. And they may not report the diarrhea, so you have to ask about it. The more symptoms, if they have symptoms that last longer, that means they're shedding longer, and also their immunity kicks in later. Common symptoms in adults are dry cough, fever, and fatigue, but it's hypoxia in old people. There are patient family office systems level issues that you have to do to manage this, and so you have to think about those larger things. So we start with communication, how transmission works, including with talking and hand washing, a paradigm shift when anybody can be the vector. There's virus everywhere on surfaces, air, but shedding versus transmission. Specifics distinguish the coronavirus disease from influenza and other upper respiratory infections. So you don't get the sneezing, you get coughing. And if it changes, if you now have a co-infection with flu, you might sneeze and you might transmit more efficiently. Also, if allergies are cropping up, you may have a new reason to sneeze. And if you have coronavirus, it may actually exacerbate the spread of that locally. So changing practice to accommodate the changing realities to deal with shortages. And a last word about the current effective treatments in COVID that I promised I would give. This is the word, is what we can say about available treatments. There aren't enough data to assess the risk versus benefit of any of the treatments as of this date, although we're hopeful about some. So thank you very much for attending, and I hope this was useful to you. Have a nice day.